I'm Harriette Van Spall, cardiologist and associate professor of medicine from McMaster University, and I'm delighted to have with me today two friends who are going to conduct this masterclass on combating burnout and hostility in the cardiovascular workplace. My first guest is Dr. Laxmi Mehta, the Vice Chair of Wellness, Department of Medicine, and Professor of Medicine at The Ohio State University. Welcome, Dr. Mehta.
Thank you, Dr. Van Spall. It's a pleasure to be here.
And my second guest is Dr. Garima Sharma, who's an assistant professor of medicine in the Department of Cardiology and Medicine at the Johns Hopkins University School of Medicine. Welcome, Dr. Sharma.
Thank you so much, Dr. Van Spall. It's a pleasure to be here.
So we're here to talk about the impact of COVID-19 and of hostility and discrimination in the cardiology workplace. I'm going to start by asking Dr. Mehta about a recent study that she conducted that was a global survey of ACC members. Dr. Mehta, would you tell us what the rationale was for your survey and what the methods were?
Sure. Thank you, Dr. Van Spall. So the rationale for the study was that we know burnout existed in cardiology prior to the pandemic. But what we recognized was that burnout really took a hit at the time of the pandemic. More and more clinicians across the globe were facing higher stress levels. And what we wanted to pinpoint was, did our levels of burnout increase at the time of the pandemic? How did our clinicians feel about their organization, and did they feel supported or not? So those were key things that we wanted to investigate in this study. And the way we did it was we used the Mini-Z burnout survey, which we've used on our prior ACC survey sets regarding burnout. And we asked the members to kind of tell us if they felt they were okay, were they stressed, or were they burned out, and they had to self-reflect how they felt prior to the pandemic, and then how they felt at the time of peak pandemic time for them. And we recognize that the peak of the pandemic varied by state within the US as well as country worldwide. So they had to self-reflect that, and that kind of helped us determine a pre-pandemic and a peak pandemic burnout levels.
So these were all cardiologists across cardiovascular specialties rather?
Well, that's a great question. We actually chose not to just look at cardiologists. So we looked at US cardiologists and international cardiologists, but also fellows in training within the US and the cardiovascular team professionals within the United States.
Okay, and how did you disseminate your survey?
The survey was disseminated via email across the globe, and we just took just a random sample of the ACC's membership.
Okay, so how many people received the survey and how many people responded?
We had more than 10,000 people receive the survey and about 1,288 that completed the survey. The highest proportions were amongst the cardiologists who completed the survey, but we had a good amount that were trainees as well as CVT members.
Okay, and what were your primary findings?
So the primary thing that we wanted to share is that about 20% of all cardiovascular professionals across the globe felt burned out pre-pandemic, and that nearly doubled to 38% at peak pandemic levels. Now, the highest rates were amongst cardiovascular professionals, cardiovascular team members, as well as fellows in training, and lowest was amongst the international cardiologists. So we know there's some variations there. And the other thing that we found out was that most of the cardiovascular professionals didn't feel that their institutes or healthcare organizations were necessarily providing them the support that they needed and wanted.
Dr. Sharma, was your methodology similar to this in the survey that you conducted?
Yeah, a little bit different in the sense that we didn't actually specifically ask for burnout. We were interested in the global prevalence of hostility in the workforce. And we define hostility as a combination of certain types of mistreatment or toxic behaviors at workplace. Discrimination of any kind, age, race, gender, sexual orientation, religion, and harassment, sexual harassment and emotional harassment. We did not really specifically look for the entire cardiovascular workforce. We were interested in cardiologists, and this was a global survey. So we were interested in not just North America, but also South America, Middle East, Eastern Europe, Asia, and Oceania, Australia, countries that we don't think we have ever surveyed before from this perspective. So in that sense, it was an ACC survey, and it was a global ACC survey, but it was limited to practicing cardiologists.
Right, and there's an interplay between hostility and burnout, and you defined hostility for the purposes of your study. Dr. Mehta, how did you define burnout, and how does burnout differ from, say, situational depression, for example?
Sure, that's a great question. So we use the mini-Z survey question on burnout, and that question is using your own definition of burnout. You would select either that I'm enjoying my work and I have no symptoms of burnout, or I'm stressed and I feel burned out, but I don't feel burned out. Or the burnout category would be I'm definitely burning out and have symptoms of burnout, or I'm having symptoms that won't go away, or I'm just completely burnout where I may need to seek help. Burnout's different than depression. I mean, they can coexist, but they also can be clearly different. Burnout is like depersonalization, cynicism, being frustrated with your work environment and having the lack of control, whereas depression is just the mood of, in a feeling like you can't change things, feeling sad. There's lots of variations in that, but they're clearly different phenomenons.
Right, with some interplay like irritability and feelings of guilt and feeling negative. Probably some correlation there that needs to be teased out more. Now, you alluded to the differences between your US workforce and findings in the international community. Why do you think that was? Did you look at some of the structural policy licensing aspects, the role that clinicians play in the US versus outside the US?
That's a great question. We didn't look at that. We only had less than 400 international survey respondents. This was just to be a pulse survey, just to get a general sense of what our ACC membership was doing. So we didn't look at that, but if we had to speculate, we'd say that, these are people across the globe. So the variations can be different. Also, was it skewed by those countries that haven't experienced the pandemic yet, or variation based on if their countries had them be frontline workers as cardiologists, or they didn't, because that really varied based on country as well. So there is going to be some survey bias. In addition, there's a difference. The survey that Dr. Sharma is talking about, we launched them around similar times, so no survey respondent completed both studies.
Right. Tell us about your findings, Dr. Sharma. What did you see in your survey that might have highlighted some of the factors associated with maladaptive, dysfunctional workplace behaviors?
Yeah, no, that's a great question. And thank you for asking that. Our objective was to assess practice settings and the overall toxic culture of cardiology. We went in there thinking that we're going to find something bad. So, in some ways, we kind of predicted based on, our own behaviors that, that there may be a high prevalence of toxicity and hostility. And not surprising, this isn't just a United States problem. Overall, hostility of any kind was pervasive. No country was immune. No region was immune. Overall, the rates were about 44% globally of these kind of experiences that cardiologists were facing. If you break it down into details of what were the high-risk features, women overall across the globe were felt discriminated against, felt harassed, reported higher rates of harassment and discrimination. Early career cardiologists felt that more than late career cardiologists. Those were the main features. But overall, our study didn't find a very high rate of sexual harassment as compared to some of the other reported data. And we reflected on this a little bit, and perhaps this may be with, their own cultural environments. This is a global survey. Some people may be afraid of, speaking up, or it is a self-reported behavioral sort of a survey. So if there are changes across the globe, it perhaps maybe have left to underreporting. But we weren't, we were disturbed by our findings, and kind of just gives us a sense of how much more work we need to do in cardiology to make it a viable and an accessible workplace for everybody.
Right, and there's such a spectrum of gender harassment. Sexual harassment's one component, but there are other hostile behaviors that women in particular are subject to, and it's sort of how you perceive the behavior that's being demonstrated in a lot of these self-reported surveys. Dr. Mehta, did you find any demographic differences in self-reported burnout in your survey? Were there any groups that were more susceptible to burnout?
Yeah, our data showed that mid-career cardiologists tend to burn out more often or at higher rates than early career or fellows in training, or even compared to late career. And most importantly, is women tend to burn out more frequently than men. It's higher rates. But I would say that, burnout, harassment, discrimination, all of that's not gender specific entirely. We do see higher rates among women, but it's happening in men too. So it's an everybody's issue.
Mm-hmm. Now, what would each of you say are 3 or 4 strategies that institutions could implement to tackle these issues that have been pervasive and have been reported over time, but seem to be an ongoing problem that impair performance, right? Both academic performance, the service we can provide our patients, and the roles we play in the wider academic community. What are some things that institutions can do? I'll start with you first, Dr. Sharma.
Sure. No, thank you for that question, because now we have data. And so what do we do with this data, and how do we crystallize this data into actionable items that are specific for a particular workplace, right? So I do think that there's going to be different solutions for different environments, but in general, there needs to be broad pillars of intervention, as you may say, and those may be first recognizing that this is a problem, prioritizing this as a problem, because a healthy workforce, as you pointed out, has outcomes that impact patients and patient care. And so zero tolerance policy towards egregious behavior, if it's reported, make it easy to report rather than victim shaming and victim blaming. Each institution probably needs to come up with metrics of assessment of burnout and discrimination and harassment, which are institutional specific. And I think then the other thing comes to, beyond implicit bias training, right? Beyond workshops that tell us what the problem is, to involve the workforce into finding solution for implementation, make them very involved with this, as if it's just as important as, reimbursement for kind of clinical care. So I think beyond that, and allyship, finding ways to speak up in a way that you support an environment that leads to cultural change. So these are some, very broad pillars. I think obviously each institution has to come up with some granular changes that are institutional specific.
How about you, Dr. Mehta?
Yeah, I agree with Dr. Sharma, and I would say, burnout, the culture of harassment or lack of harassment is really local. So just like all politics are local, that is all local. And healthcare organizations need to be accountable for the mental health and the well-being of their employees. And they need to also have senior leadership that's really dedicated to that role of improving the psychosocial health of their employees. Healthcare organizations need to have regular assessment of their employees that provide meaningful data and they're ready to act upon it. Much of the investment that healthcare organizations spend within well-being of their employees should really focus on the organizational factors that are contributing to burnout, high stress levels, the hostile work environment, rather than focusing just on the personal resiliency and telling, these breaks and yoga. Those aren't the solutions. It's the environment that has to be really fixed. In addition, we have an opportunity as researchers, as educators, to change the next generation for culture. And if we start early with these fellows in training and with the residents about what is psychosocial well-being, what are the factors that you can fix yourself to improve burnout, and how can we avoid a hostile work environment? Perhaps we can make grander changes for the future.
Agreed. I think that some of the strategies entail transforming culture from top-down efforts, choosing leadership in a manner that enhances the well-being and performance. We typically have closed processes for leadership selection at many institutions. We value those that bring in grant funds and have a certain standing versus those who can lead both as moral and ethical leaders and as clinicians who are researchers, and also have a mechanism for advancing the right kind of people by rewarding the right kind of behaviors and ensuring that we're comprehensive in the way we evaluate our faculty members, and then recruitment as well. I think choosing the right people in medicine, there's so many things we could say about what needs to be done. I think an important tip for all of us is to not be silent bystanders when we witness hostility, when we witness a struggling colleague, to step in and be agents of change, perhaps, and tackle the issue in a multifaceted way. I thank you both for your time this morning. Congratulations, Dr. Mehta, on your presentation. Congratulations, Dr. Sharma, on your publication. You both have been very productive, particularly in recent weeks. I'm enjoying all of these documents that are being rolled out. I wish you both well, and I hope to see you again soon.
Thank you very much.
Thank you.